Welcome to this video entitled Tuberculous Meningitis. Tuberculous meningitis, or TBM, is the most severe form of tuberculosis that affects areas outside the lungs. It happens when the tuberculosis bacteria spread to the brain and the protective membranes around it. This makes tuberculous meningitis a medical emergency that requires rapid diagnosis and treatment. One of the most concerning facts about tuberculous meningitis is how often it affects very young children. Kids under 5 years old are especially vulnerable because their immune systems are still developing. In many cases, the symptoms can begin subtly. A child may seem tired, irritable, or develop a persistent fever before more serious neurological problems appear. Tuberculous meningitis is also much more common in people living with HIV. Since HIV weakens the immune system, the body struggles to control the tuberculosis infection. This allows the bacteria to spread more easily from the lungs to the brain. In regions where HIV and tuberculosis overlap, tuberculous meningitis remains a major public health challenge. Another reason tuberculous meningitis is so feared is its high mortality and morbidity rate worldwide. Even with treatment, many patients can experience long-term complications. These may include memory problems, seizures, hearing loss, difficulty learning, or physical disabilities. Delayed diagnosis greatly increases the risk of severe outcomes. Symptoms often develop gradually over days or weeks. Patients may first complain of headaches, fever, vomiting, or neck stiffness. As the disease progresses, confusion, altered consciousness, and even coma can occur. Because the symptoms can resemble other infections, early recognition is critical. Doctors diagnose tuberculous meningitis using a combination of clinical examination, brain imaging, and analysis of cerebrospinal fluid obtained through lumbar puncture. Treatment usually involves a long course of anti-tuberculosis medications, often combined with steroids to reduce inflammation in the brain. Prevention plays a major role in reducing the burden of tuberculous meningitis. Early detection and treatment of pulmonary tuberculosis can stop the infection from spreading. Vaccination with BCG also offers some protection, especially in children. Although tuberculous meningitis remains a dangerous disease, advances in diagnostics, treatment strategies, and public health awareness are helping improve outcomes around the world. The pathogenesis of tuberculous meningitis begins with a primary tuberculosis infection, usually in the lungs. At this early stage, the bacteria may not stay confined to the respiratory system. Instead, they can spread through the bloodstream to different parts of the body, including the brain. This process is known as hematogenous dissemination. Once the bacteria reach the brain, they form tiny lesions called rich foci. These are small collections of tuberculosis bacteria that develop beneath the brain's surface lining, known as the subpial region, or near the ventricular lining, called the subependymal region. At this point, the infection may remain silent for weeks, months, or even longer without obvious symptoms. The real danger begins when one of these rich foci ruptures into the subarachnoid space. This space contains cerebrospinal fluid that surrounds and protects the brain and spinal cord. When the bacteria suddenly enter this area, the immune system reacts aggressively. This marks the beginning of tuberculous meningitis. The body's immune response is intense because it recognizes the invading bacteria as a major threat. Large numbers of inflammatory cells and chemical mediators are released into the cerebrospinal fluid. These inflammatory response markers trigger swelling and irritation around the brain. As inflammation increases, thick exudates begin to collect around the base of the brain. These sticky inflammatory materials can block the normal flow of cerebrospinal fluid. This may lead to hydrocephalus, a dangerous buildup of fluid inside the brain that increases pressure within the skull. Inflammation can also affect nearby blood vessels. The vessels may become narrowed or blocked, reducing blood supply to brain tissue. This raises the risk of stroke-like damage, especially in critical areas controlling movement, speech, and consciousness. At the same time, the cranial nerves may become compressed by the inflammatory process. This explains why some patients develop double vision, hearing loss, facial weakness, or difficulty swallowing during advanced stages of the disease. One of the most challenging aspects of tuberculous meningitis is that the disease often develops gradually. Early symptoms such as fever, headache, fatigue, or mild confusion may seem nonspecific. However, as inflammation spreads, neurological symptoms become more severe and life-threatening. Understanding the pathogenesis of tuberculous meningitis is important because it explains why early diagnosis and rapid treatment are so critical. The damage caused by inflammation can continue even after the bacteria are controlled. This is why doctors often use anti-inflammatory medications alongside anti-tuberculosis drugs to reduce brain injury and improve patient outcomes. Medical staging in tuberculous meningitis, or TBM, is one of the most important tools doctors use to assess how severe the disease has become. The stage of the illness helps predict the patient's chances of recovery and guides urgent treatment decisions. In simple terms, the earlier the stage, the better the outcome is likely to be. Stage 1 is considered the earliest and mildest phase of tuberculous meningitis. At this stage, the patient is still fully conscious and alert. There are usually no major neurological deficits, meaning the brain and nerves are still functioning relatively well. Patients may complain of headaches, fever, vomiting, or general weakness, but they can still communicate normally and respond appropriately. Because symptoms may appear mild, this stage is sometimes overlooked or mistaken for a common viral illness. Early diagnosis during stage 1 offers the best chance for full recovery. If treatment begins quickly, many patients can avoid serious brain damage and long-term complications. This is why awareness and early recognition are so important. Stage 2 marks a progression of the disease. At this point, inflammation inside the brain becomes more severe, and neurological symptoms begin to appear. Patients may become lethargic, confused, irritable, or unusually drowsy. Their level of consciousness starts to decline, even though they may still respond to questions or commands. Mild focal neurological deficits may also develop during stage 2. One common example is cranial nerve palsy. This happens when nerves controlling the eyes, face, or hearing become affected by inflammation. Patients may develop double vision, facial weakness, drooping eyelids, or difficulty hearing. Stage 3 is the most severe and life-threatening phase of tuberculous meningitis. Patients in this stage often have profound alterations in consciousness and may fall into a coma. Seizures are common and indicate severe irritation of the brain tissue. Dense neurological deficits can also occur, including paralysis, severe weakness, or loss of speech. At this advanced stage, pressure inside the skull may rise dangerously due to swelling or blocked cerebrospinal fluid flow. Brain injury can become widespread, and the risk of death increases dramatically. Even survivors may experience permanent neurological disabilities. Among all clinical factors in tuberculous meningitis, staging remains the strongest predictor of outcome. Patients diagnosed in stage 1 generally have the best prognosis. Those diagnosed in stage 3 face much higher risks of mortality and long-term complications. This staging system highlights a critical message in tuberculous meningitis management. Early diagnosis saves lives. Recognizing symptoms early and starting treatment before neurological damage becomes severe can make the difference between recovery and lifelong disability. The clinical features of tuberculous meningitis, or TBM, often develop slowly and quietly at first. Unlike sudden bacterial meningitis, tuberculous meningitis usually has an insidious or subacute onset. This means symptoms appear gradually over days or even weeks, making the disease more difficult to recognize in its early stages. Many patients begin with vague prodromal symptoms that may seem harmless at first. A low-grade fever is common and may persist for long periods without an obvious cause. Patients often complain of malaise, which is a general feeling of weakness, fatigue, or discomfort. Persistent headaches are also an early warning sign and may gradually become more severe over time. Because these early symptoms are nonspecific, tuberculous meningitis can easily be mistaken for viral infections, stress, or other common illnesses. This delay in diagnosis is one of the reasons the disease remains so dangerous worldwide. As the infection progresses, inflammation around the brain and spinal cord becomes more intense. This leads to the development of classic meningeal signs. One of the most important is neck stiffness, also called meningismus. Patients may find it painful or difficult to bend the neck forward because the inflamed meninges become extremely sensitive. Headaches usually worsen during this stage and may be accompanied by vomiting, sensitivity to light, or increasing drowsiness. Some patients become irritable or confused as pressure and inflammation inside the brain continue to rise. A major feature of tuberculous meningitis is the appearance of focal neurological signs. These occur when specific nerves or regions of the brain become damaged by inflammation. Among the most common findings are cranial nerve palsies. The sixth cranial nerve, also known as the abducens nerve or CN6, is most frequently affected. This nerve controls eye movement, especially the ability to move the eye outward. When it becomes inflamed or compressed, patients may develop double vision or difficulty focusing their eyes properly. Other cranial nerves may also become involved as the disease worsens. Facial weakness, hearing problems, drooping eyelids, or difficulty swallowing can occur depending on which nerves are affected. In advanced cases, patients may develop seizures, severe confusion, weakness of the limbs, or even coma. These signs suggest widespread involvement of the brain and indicate a medical emergency. One of the key lessons in tuberculous meningitis is that symptoms often begin subtly before progressing to severe neurological disease. Early recognition of persistent headache, fever, neck stiffness, and cranial nerve abnormalities can make a major difference in patient survival. The earlier tuberculous meningitis is diagnosed and treated, the greater the chance of preventing permanent brain injury and long-term neurological complications. Cerebrospinal fluid, or CSF, analysis plays a major role in diagnosing tuberculous meningitis, also known as TBM. Doctors obtain this fluid through a lumbar puncture, commonly called a spinal tap. Since the CSF surrounds the brain and spinal cord, it provides important clues about what is happening inside the nervous system. One of the hallmark findings in tuberculous meningitis is pleocytosis. This means there is an increased number of white blood cells in the cerebrospinal fluid. In most cases, the cells are predominantly lymphocytes, which are immune cells involved in chronic infections like tuberculosis. The cell count usually ranges from about 100 to 500 cells per microliter. This lymphocytic response reflects the body's ongoing attempt to fight the tuberculosis bacteria inside the central nervous system. Unlike acute bacterial meningitis, where neutrophils dominate, tuberculous meningitis tends to produce a slower and more chronic inflammatory pattern. Another important finding is a markedly elevated protein level in the CSF. Protein concentrations often rise between 100 and 500 milligrams per deciliter. This increase occurs because inflammation damages the blood-brain barrier, allowing proteins to leak into the cerebrospinal fluid. High protein levels are significant because they indicate severe inflammation within the meninges and surrounding brain tissue. In advanced cases, the protein concentration may become extremely high due to extensive tissue injury and impaired CSF circulation. Low glucose levels are another classic feature of tuberculous meningitis. This condition is known as hypoglycemia. In simple terms, the glucose level in the CSF becomes much lower than normal. Doctors often compare CSF glucose to blood glucose levels, and in tuberculous meningitis, the CSF to plasma glucose ratio is usually less than 0.5. The drop in glucose happens because inflammatory cells and bacteria consume glucose within the cerebrospinal fluid. At the same time, inflammation interferes with the normal transport of glucose into the CSF. The appearance of the cerebrospinal fluid can also provide valuable diagnostic clues. In many patients, the fluid appears clear, especially during early stages of the disease. However, it may sometimes look xanthochromic, meaning it develops a yellowish discoloration caused by protein breakdown and inflammation. One of the most classic descriptions in tuberculous meningitis is the formation of a cobweb clot, also known as a pellicle. When the CSF is left standing for several hours, a delicate web-like film may form on the surface due to the high protein and fibrin content. Although not always present, this finding has historically been strongly associated with tuberculous meningitis. Together, these CSF findings help doctors distinguish tuberculous meningitis from other forms of meningitis. Early recognition of these patterns is critical because rapid diagnosis and treatment greatly improve the chances of survival and reduce the risk of permanent neurological damage. Identifying Mycobacterium tuberculosis in tuberculous meningitis, or TBM, can be extremely challenging. The number of bacteria present in the cerebrospinal fluid is often very low, making laboratory confirmation difficult. Even so, accurate identification is critical because early treatment can save lives and reduce permanent brain damage. One of the oldest diagnostic methods is the acid-fast bacilli smear, commonly called the AFB smear. In this test, the cerebrospinal fluid is stained and examined under a microscope to look for tuberculosis bacteria. Although the test is simple and widely available, its sensitivity is relatively low in tuberculous meningitis. This means many patients with the disease may still have a negative smear result. However, the diagnostic yield improves when larger volumes of cerebrospinal fluid are collected and processed carefully. High-speed centrifugation helps concentrate the bacteria, increasing the chances of detecting them under the microscope. Culture remains the gold standard for confirming tuberculosis infection. In this method, the cerebrospinal fluid is placed in special media that allow Mycobacterium tuberculosis to grow. A positive culture provides strong evidence of infection and also allows doctors to test which antibiotics the bacteria are sensitive to. The major drawback of culture is time. Tuberculosis bacteria grow very slowly, so results may take anywhere from 2 to 8 weeks. In critically ill patients with tuberculous meningitis, waiting that long can be dangerous. This is why treatment is often started before culture confirmation becomes available. Modern molecular tests have greatly improved the speed of tuberculous meningitis diagnosis. One of the most important advances is the gene-expert MTB-RIF test. This rapid test can detect tuberculosis DNA directly from the cerebrospinal fluid within a few hours. In addition to identifying the bacteria, gene-expert can also detect resistance to rifampicin, one of the key anti-tuberculosis drugs. Detecting rifampicin resistance early is extremely important because it may indicate multi-drug resistant tuberculosis, which requires different treatment strategies. The newer Expert Ultra test is even more sensitive than the original gene-expert. It can detect smaller amounts of bacterial DNA, making it especially useful in tuberculous meningitis, where bacterial numbers are often very low. Despite these advances, one critical point must always be remembered. A negative molecular test does not exclude the diagnosis of tuberculous meningitis. Some patients with true tuberculous meningitis may still test negative because the bacterial load is too small to detect. For this reason, doctors do not rely on laboratory tests alone. Diagnosis is usually based on a combination of clinical symptoms, cerebrospinal fluid findings, brain imaging, and laboratory investigations. In many cases, treatment must begin based on strong clinical suspicion, even before confirmation is obtained. In tuberculous meningitis, delaying therapy while waiting for perfect test results can lead to devastating neurological damage or death. Imaging plays a major role in diagnosing tuberculous meningitis, or TBM, especially when symptoms are severe or the diagnosis is uncertain. Brain imaging helps doctors identify inflammation, complications, and areas of brain injury caused by the infection. Among all imaging techniques, contrast-enhanced MRI is considered the modality of choice for tuberculous meningitis. MRI provides much clearer detail of the brain, meninges, and blood vessels compared to standard CT scans. The use of contrast dye also helps highlight areas of active inflammation. One of the classic imaging patterns in tuberculous meningitis is a diagnostic triad. This includes basal meningeal enhancement, hydrocephalus, and cerebral infarction. Together, these findings strongly support the diagnosis of tuberculous meningitis. Basal meningeal enhancement occurs when inflamed meninges at the base of the brain become visible after contrast injection. On MRI, these areas appear brighter because inflammation causes abnormal leakage of contrast material into the surrounding tissues. This finding is important because tuberculous meningitis tends to concentrate around the basal cisterns at the bottom of the brain. Thick inflammatory exudates collect in these spaces and may surround important nerves and blood vessels. Hydrocephalus is another common imaging feature. In tuberculous meningitis, inflammatory material can block the normal flow and absorption of cerebrospinal fluid. As fluid builds up inside the ventricles, pressure within the skull increases. Patients with hydrocephalus may develop worsening headaches, vomiting, drowsiness, or changes in consciousness. In severe cases, emergency procedures may be needed to drain excess fluid and relieve pressure on the brain. Cerebral infarctions are also frequently seen in tuberculous meningitis. These are areas of brain tissue damage caused by interrupted blood flow. Inflammation around the blood vessels can lead to narrowing, blockage, or clot formation. In tuberculous meningitis, infarctions most commonly occur in the medial perforating territory. This includes deep brain structures such as the basal ganglia and thalamus. These regions are supplied by small penetrating arteries that are highly vulnerable to inflammatory damage. Damage in these areas can lead to weakness, movement disorders, speech problems, altered consciousness, or long-term neurological disability. The presence of infarction on imaging usually indicates more advanced disease and a poorer prognosis. Another important imaging feature is the presence of tuberculomas. These are localized granulomas formed by the immune system in response to tuberculosis infection. Tuberculomas may appear as single or multiple rounded lesions within the brain tissue. Depending on their size and location, tuberculomas can cause seizures, headaches, focal weakness, or symptoms related to increased intracranial pressure. Overall, imaging not only helps confirm the diagnosis of tuberculous meningitis, but also reveals the extent of brain involvement and complications. Early MRI evaluation can guide treatment decisions and improve patient outcomes before irreversible brain injury occurs. Treating tuberculous meningitis, or TBM, requires aggressive and prolonged antimicrobial therapy. Because the infection affects the brain and nervous system, treatment must begin as early as possible to prevent permanent neurological damage and reduce the risk of death. The first stage of treatment is called the intensive phase. This phase usually lasts for the first 2 months and involves 4 powerful anti-tuberculosis medications. These drugs are isoniazid, rifampin, pyrazinamide, and ethambutol. Each medication plays a specific role in attacking the tuberculosis bacteria. Isoniazid is especially important because it penetrates well into the cerebrospinal fluid and reaches high concentrations inside the brain. Rifampin is another key drug with strong bactericidal activity against Mycobacterium tuberculosis. Pyrazinamide works particularly well in acidic environments where tuberculosis bacteria may hide within inflamed tissues. Ethambutol is added to help prevent the development of drug resistance during the early phase of treatment. Using multiple drugs together is critical because tuberculosis bacteria can quickly become resistant if only one medication is used. Combination therapy increases the chances of completely eliminating the infection. After the intensive phase, patients move into the continuation phase. This stage typically lasts between 7 and 10 months. During this period, treatment continues with 2 core medications, isoniazid and rifampin. Although patients may begin to feel better during this stage, the infection is not fully eradicated. Tuberculosis bacteria can survive deep within tissues for long periods, so prolonged therapy is essential to prevent relapse. In total, tuberculous meningitis treatment usually lasts between 9 and 12 months. In some complicated cases, therapy may continue even longer depending on the patient's response, immune status, and presence of complications such as hydrocephalus or stroke. One of the most important principles in tuberculous meningitis management is early initiation of treatment. Doctors often begin therapy before microbiological confirmation is obtained. This is because laboratory tests for tuberculous meningitis can be slow or sometimes negative, even in patients who truly have the disease. Waiting for definitive confirmation may allow the infection to progress and cause irreversible brain injury. In tuberculous meningitis, every day of delay can worsen neurological damage and reduce the chances of recovery. For this reason, treatment is frequently started based on strong clinical suspicion, imaging findings, and cerebrospinal fluid analysis. Early empirical therapy has saved countless lives worldwide. In addition to antimicrobial drugs, many patients also receive corticosteroids to reduce inflammation and swelling around the brain. Supportive care may include seizure control, management of hydrocephalus, and rehabilitation for neurological deficits. With prompt diagnosis and proper treatment, many patients can recover successfully. However, delayed therapy remains one of the leading causes of disability and mortality in tuberculous meningitis. Dexamethasone plays a critical role in the treatment of tuberculous meningitis, or TBM. While anti-tuberculosis drugs target the bacteria itself, dexamethasone helps control the intense inflammation that develops around the brain and spinal cord. In tuberculous meningitis, much of the damage is caused not only by the infection, but also by the body's immune response. As the immune system fights the tuberculosis bacteria, severe swelling and inflammatory exudates can build up inside the brain. This inflammation may increase intracranial pressure, damage blood vessels, and compress important nerves. To reduce this dangerous inflammatory response, dexamethasone is recommended for all patients with tuberculous meningitis, regardless of disease stage. Whether the patient presents with mild symptoms or advanced neurological complications, corticosteroid therapy has become a standard part of treatment. The medication is usually given as a tapered course over 6 to 8 weeks. Treatment often begins with higher doses during the acute phase of illness, when inflammation is most severe. The dose is then gradually reduced over time to avoid complications associated with sudden withdrawal of steroids. One of the major benefits of dexamethasone is its ability to significantly reduce mortality in tuberculous meningitis. Studies have shown that patients receiving corticosteroids are more likely to survive compared to those treated with anti-tuberculosis medications alone. This survival benefit is especially important in severe cases where brain swelling, hydrocephalus, or vascular inflammation may rapidly become life-threatening. By decreasing inflammation, dexamethasone helps reduce pressure inside the skull and may improve blood flow to vulnerable brain tissues. The drug may also help relieve symptoms such as headache, vomiting, neck stiffness, and altered consciousness. In some patients, neurological improvement becomes noticeable within days after starting steroid therapy. However, dexamethasone also has important limitations. Although it reduces mortality, it does not necessarily prevent long-term neurological disability in survivors. Many patients who recover from tuberculous meningitis may still experience complications such as memory impairment, seizures, hearing loss, movement disorders, or learning difficulties. This happens because some neurological damage may already be irreversible by the time treatment begins. Stroke-like infarctions, nerve injury, or prolonged increased intracranial pressure can leave permanent effects even after the infection is controlled. For this reason, early diagnosis remains essential. Starting both antimicrobial therapy and dexamethasone before extensive brain injury develops offers the best chance for improved outcomes. Doctors also monitor patients carefully during steroid therapy because prolonged corticosteroid use can cause side effects. These may include elevated blood sugar, increased infection risk, stomach irritation, or mood changes. Despite these concerns, the benefits of dexamethasone in tuberculous meningitis generally outweigh the risks when used appropriately. Today, dexamethasone remains one of the most important supportive therapies in the management of tuberculous meningitis and continues to save lives worldwide. Managing complications is one of the most important parts of treating tuberculous meningitis, or TBM. Even after anti-tuberculosis medications are started, patients may still develop serious neurological problems caused by inflammation, pressure changes, or immune reactions inside the brain. One of the most common and dangerous complications is hydrocephalus. This occurs when inflammatory material blocks the normal circulation of cerebrospinal fluid. As fluid accumulates inside the brain's ventricles, intracranial pressure begins to rise. Patients with hydrocephalus may develop worsening headaches, vomiting, confusion, drowsiness, or difficulty staying awake. In severe cases, the condition can rapidly become life-threatening if pressure is not relieved. To manage hydrocephalus, some patients require surgical procedures. One option is a ventriculoperitoneal shunt, commonly called AVP shunt. This device diverts excess cerebrospinal fluid from the brain into the abdominal cavity, where it can be absorbed safely. Another treatment option is endoscopic third ventriculostomy, or ETV. In this procedure, surgeons create a small opening within the brain's ventricular system to allow fluid to flow more freely and bypass the blockage. Another major complication in tuberculous meningitis is hyponatremia, which means abnormally low sodium levels in the blood. This problem often develops due to conditions called SIADH, or syndrome of inappropriate antidiuretic hormone secretion, and cerebral salt wasting, known as CSW. Although both conditions lower sodium levels, they occur through different mechanisms. SIADH causes the body to retain excess water, while cerebral salt wasting leads to excessive sodium loss through the kidneys. Both can produce symptoms such as weakness, confusion, seizures, and worsening neurological status. Careful monitoring of electrolytes is therefore essential in tuberculous meningitis patients. Treatment depends on identifying the underlying cause and correcting sodium levels safely without causing additional brain injury. Another challenging complication is the paradoxical reaction. In this situation, patients may appear to worsen after treatment has already started. Existing brain lesions may enlarge, or new neurological symptoms may suddenly develop despite appropriate therapy. This reaction occurs because the recovering immune system mounts a stronger inflammatory response against tuberculosis antigens. In HIV-infected patients, this phenomenon is often referred to as immune reconstitution inflammatory syndrome, or IRIS. Although paradoxical reactions can be alarming, they do not always mean treatment failure. Doctors may continue anti-tuberculosis therapy while adjusting corticosteroids to control inflammation. Even after successful treatment, many patients are left with permanent neurological sequelae. These long-term complications may include vision loss, hearing impairment, memory problems, learning difficulties, or weakness affecting one side of the body, known as hemiparesis. These lasting effects highlight the importance of early diagnosis and rapid treatment. The sooner inflammation and brain injury are controlled, the greater the chance of reducing disability and improving long-term quality of life. The outcomes of tuberculous meningitis, or TBM, depend heavily on how early the disease is recognized and treated. Although modern therapies have improved survival, tuberculous meningitis remains one of the deadliest forms of tuberculosis affecting the nervous system. Mortality rates are especially high in infants and in patients who present with stage 3 disease. Infants are particularly vulnerable because their immune systems are still immature, making it harder for their bodies to control the infection. In very young children, the disease can progress rapidly and cause severe brain swelling, hydrocephalus, or widespread neurological injury. Patients with stage 3 tuberculous meningitis face the greatest risk of death because they already have advanced brain involvement at the time of diagnosis. These patients may present with coma, seizures, severe weakness, or profound alterations in consciousness. At this stage, inflammation and vascular damage inside the brain are often extensive. One of the most important messages in tuberculous meningitis management is that early diagnosis saves lives. Recognizing symptoms before severe neurological damage develops can dramatically improve survival rates. Persistent headaches, fever, neck stiffness, confusion, or cranial nerve abnormalities should never be ignored in high-risk patients. Rapid initiation of treatment is equally critical. In many cases, doctors begin anti-tuberculosis therapy based on strong clinical suspicion even before laboratory confirmation is available. Waiting too long for test results may allow irreversible brain injury to occur. Early treatment helps control both the infection and the inflammatory response responsible for much of the neurological damage. Corticosteroids such as dexamethasone are often added to reduce swelling and improve survival outcomes. Even when patients survive tuberculous meningitis, recovery is often long and challenging. Many survivors experience permanent neurological complications caused by strokes, nerve injury, or prolonged increased intracranial pressure during the illness. Some patients may develop vision loss or hearing impairment due to damage involving cranial nerves or brain structures responsible for sensory function. Others may experience weakness on one side of the body, known as hemiparesis, which can affect walking and daily activities. Cognitive impairment is also common among survivors. Problems with memory, concentration, learning, and behavior may persist long after the infection has resolved. Children who survive tuberculous meningitis may struggle academically or experience developmental delays. Because of these long-term effects, comprehensive neurorehabilitation is often required. Rehabilitation may include physical therapy to improve strength and mobility, occupational therapy to restore independence, and speech therapy for communication or swallowing difficulties. Psychological and educational support are also important, especially for children recovering from neurological injury. Recovery can continue for months or even years after the initial infection. Overall, tuberculous meningitis remains a devastating disease, but outcomes improve significantly with early recognition, prompt treatment, and long-term rehabilitation support. The earlier intervention begins, the greater the chance of survival and meaningful neurological recovery. We will now do a few case reviews. One of the most important questions in understanding tuberculous meningitis, or TBM, is how the infection actually reaches the central nervous system. Many people assume the bacteria spread directly from the lungs straight into the meninges, but the real mechanism is more complex. The correct answer is B. Rupture of a pre-existing rich focus into the subarachnoid space. Here's how it happens. Tuberculosis usually begins as a primary infection in the lungs. From there, the bacteria can spread through the bloodstream to different organs, including the brain. This early spread is called hematogenous dissemination. Once the bacteria reach the brain, they form tiny hidden lesions known as rich foci. These small tuberculous granulomas develop beneath the lining of the brain or near the ventricular surfaces. At this stage, the patient may have no neurological symptoms at all. The infection can remain dormant for weeks, months, or sometimes even years. The real problem begins when one of these rich foci ruptures into the subarachnoid space, the fluid-filled area surrounding the brain and spinal cord. When the bacteria suddenly spill into the cerebrospinal fluid, the immune system reacts aggressively. This triggers a severe inflammatory response that causes swelling of the meninges, accumulation of thick exudates, and damage to nearby blood vessels and nerves. This inflammatory cascade is what leads to the clinical features of tuberculous meningitis, including headache, fever, neck stiffness, confusion, seizures, and cranial nerve palsies. Option A is incorrect because the bacteria do not usually spread directly from the lungs straight into the meninges. Instead, they first establish rich foci inside the central nervous system before rupture occurs. Option C is also incorrect. Direct invasion from the skull base or sinuses is not the typical mechanism for tuberculous meningitis. That pathway is more commonly associated with certain bacterial or fungal infections. Option D is incorrect as well because lymphatic spread from abdominal nodes is not considered the primary route leading to tuberculous meningitis. Understanding the role of the rich focus is critical because it explains why tuberculous meningitis can appear long after the initial lung infection. A patient may seem healthy for months before neurological symptoms suddenly develop. This mechanism also highlights why early detection and treatment of pulmonary tuberculosis are so important. Preventing the formation and rupture of rich foci can reduce the risk of this devastating brain infection. In tuberculous meningitis, the rupture of a tiny hidden lesion can trigger life-threatening inflammation throughout the entire central nervous system. This clinical scenario describes a patient with fever, headache, and lethargy who is still able to follow commands. No focal neurological deficits are present. The correct answer is Stage 2 tuberculous meningitis, or TBM. To understand why, it helps to review how tuberculous meningitis staging reflects the severity of brain involvement. The staging system is extremely important because it predicts both survival and long-term neurological outcome. Stage 1 is the earliest and mildest form of tuberculous meningitis. Patients are fully conscious, alert, and neurologically intact. They may complain of headache, fever, vomiting, or neck stiffness, but there are no changes in mental status and no focal neurological signs. In this case, the patient is already lethargic. That means the level of consciousness has started to decline. Even though the patient can still follow commands, the presence of altered mental status moves the patient beyond Stage 1. This is why the correct answer is Stage 2. Stage 2 tuberculous meningitis is characterized by mild to moderate changes in consciousness. Patients may become lethargic, confused, irritable, or unusually drowsy. They are often still responsive and able to obey simple commands, but their mental state is clearly abnormal. Some Stage 2 patients may also develop mild focal neurological deficits. These can include cranial nerve palsies, weakness, or abnormal eye movements. However, focal deficits are not required for the diagnosis of Stage 2. Altered consciousness alone is enough. This case specifically mentions lethargy without focal neurological signs, which fits perfectly with Stage 2 disease. Stage 3 tuberculous meningitis is much more severe. Patients usually have profound neurological impairment, including coma, seizures, or dense focal deficits such as paralysis. These patients are often critically ill and may require intensive care support. Stage 4 is not part of the classic tuberculous meningitis staging system, making option D incorrect. Recognizing Stage 2 disease is extremely important because it represents a critical window for intervention. At this point, the patient already has significant brain inflammation, but severe irreversible damage may still be preventable with rapid treatment. Early anti-tuberculosis therapy and corticosteroids can reduce inflammation, lower intracranial pressure, and improve survival. Delayed treatment may allow the disease to progress into stage 3, where mortality and long-term disability rise dramatically. This case also highlights how subtle neurological changes matter in tuberculous meningitis. A patient who simply seems unusually sleepy or less responsive may already have serious central nervous system involvement. In tuberculous meningitis, even mild lethargy should never be ignored. Early recognition of altered consciousness can make the difference between recovery and devastating neurological injury. When doctors suspect tuberculous meningitis, or TBM, one of the most important diagnostic tools is cerebrospinal fluid analysis. The cerebrospinal fluid, also called CSF, surrounds the brain and spinal cord, so changes in this fluid can reveal what is happening inside the central nervous system. The correct answer is B: low glucose, high protein, and high lymphocytes. This combination is considered highly suggestive of tuberculous meningitis and reflects the characteristic inflammatory response caused by Mycobacterium tuberculosis inside the meninges. Let's break down why these findings occur. First, glucose levels in the CSF are usually low in tuberculous meningitis. This condition is known as hypoglycemia. The tuberculosis bacteria and inflammatory cells consume glucose within the cerebrospinal fluid, while inflammation also interferes with normal glucose transport into the CSF. Doctors often compare CSF glucose to blood glucose levels. In TBM, the CSF to plasma glucose ratio is commonly less than 0.5. Low glucose is an important clue that a serious central nervous system infection may be present. Second, protein levels in the CSF are typically very high. This happens because inflammation damages the blood-brain barrier, allowing proteins to leak into the cerebrospinal fluid. Elevated protein levels often indicate significant meningeal inflammation and tissue injury. In some patients, protein concentrations can become extremely elevated, especially in advanced disease or when CSF circulation is obstructed. Third, tuberculous meningitis usually produces a lymphocytic pleocytosis. This means the white blood cells found in the CSF are mainly lymphocytes rather than neutrophils. Lymphocytes are commonly associated with chronic infections such as tuberculosis. This lymphocyte-predominant pattern helps distinguish tuberculous meningitis from acute bacterial meningitis, where neutrophils are usually the dominant inflammatory cells. Option A is incorrect because high glucose and low protein are not typical findings in tuberculous meningitis. In addition, neutrophil predominance is more suggestive of acute pyogenic bacterial meningitis. Option C is also incorrect because tuberculous meningitis generally causes elevated protein, not low protein levels. Option D is incorrect because normal glucose with no white blood cells would not fit the inflammatory profile expected in tuberculous meningitis. It is important to remember that no single CSF finding confirms tuberculous meningitis by itself. Doctors combine CSF analysis with clinical symptoms, brain imaging, and microbiological testing to make the diagnosis. Still, the classic tuberculous meningitis pattern remains very important. Low glucose, high protein, and high lymphocyte counts should immediately raise suspicion for tuberculous meningitis, especially in patients with persistent fever, headache, neck stiffness, or altered mental status. Recognizing these CSF findings early can lead to faster treatment and greatly improve the chances of survival and neurological recovery. In tuberculous meningitis, or TBM, brain imaging provides some of the most important clues for diagnosis and disease severity. One of the best-known imaging patterns in tuberculous meningitis is the classic radiologic triad. This triad includes basal meningeal enhancement, hydrocephalus, and cerebral infarction. So, the correct answer is C, cerebral infarction, specifically involving the basal ganglia region. Let's explore why this finding is so important. Basal meningeal enhancement occurs when inflammation builds up around the base of the brain. On contrast-enhanced MRI, these inflamed meninges appear brighter because contrast material leaks into the affected tissues. This is a hallmark feature of tuberculous meningitis because thick inflammatory exudates tend to collect around the basal cisterns. These exudates can surround cranial nerves and blood vessels, leading to many of the neurological complications seen in the disease. The second component of the triad is hydrocephalus. Inflammation can obstruct the normal flow of cerebrospinal fluid, causing fluid to accumulate inside the brain's ventricles. As pressure rises, patients may develop headaches, vomiting, confusion, drowsiness, or decreased consciousness. The third and final part of the triad is cerebral infarction. This refers to areas of brain tissue damage caused by interrupted blood flow. In tuberculous meningitis, inflammation around blood vessels can cause narrowing, blockage, or clot formation. These infarctions most commonly occur in the medial perforating territory of the brain. This includes deep brain structures such as the basal ganglia and thalamus. The basal ganglia are especially vulnerable because they are supplied by small penetrating arteries that can easily become compressed or inflamed. Damage in this area may lead to weakness, movement disorders, speech difficulties, or altered consciousness. The presence of infarction on imaging often suggests more advanced disease and may predict poorer neurological outcomes. Option A, midline shift, is incorrect because although it can occur in severe brain swelling or large masses, it is not part of the classic tuberculous meningitis triad. Option B, parietal lobe hemorrhage, is also incorrect. Hemorrhage is not a typical hallmark finding in tuberculous meningitis imaging. Option D, cortical atrophy, may occur later after chronic brain injury, but it is not considered part of the classic radiologic triad either. Understanding this triad is clinically important because it helps doctors recognize tuberculous meningitis early, especially in patients with unclear symptoms. Contrast-enhanced MRI is particularly useful because it can reveal these findings before severe neurological deterioration occurs. In tuberculous meningitis, the combination of basal enhancement, hydrocephalus, and cerebral infarction strongly points toward a dangerous inflammatory process affecting both the meninges and the brain itself. The treatment of tuberculous meningitis, or TBM, requires a long and carefully structured course of anti-tuberculosis medications. Because the infection affects the brain and central nervous system, therapy must be aggressive and sustained to fully eliminate the bacteria and prevent relapse. The correct answer is B, 2 months. This 2-month period is known as the intensive phase of treatment. During this stage, doctors use 4 powerful anti-tuberculosis drugs together to rapidly reduce the number of bacteria in the body. The standard medications used are isoniazid, rifampin, pyrazinamide, and ethambutol. Each drug attacks Mycobacterium tuberculosis in a different way, making combination therapy much more effective than using a single medication alone. Isoniazid is especially important in tuberculous meningitis because it penetrates the cerebrospinal fluid very well. This allows the drug to reach high concentrations inside the brain and meninges, where the infection is located. Rifampin is another key medication because of its strong bactericidal activity. It helps kill actively multiplying tuberculosis bacteria and is considered one of the most effective anti-TB drugs available. Pyrazinamide works particularly well in acidic inflammatory environments where tuberculosis bacteria may hide inside tissues. Ethambutol is included mainly to reduce the risk of drug resistance during the early phase of treatment. The goal of the intensive phase is to quickly control the infection, reduce bacterial load, and prevent further neurological damage. This phase is critical because untreated or poorly treated tuberculous meningitis can rapidly become fatal. Option A, 2 weeks, is far too short for tuberculosis treatment. TB bacteria grow slowly and require prolonged therapy for complete eradication. Option C, 6 months, is incorrect because 6 months is closer to the total treatment duration used for some forms of pulmonary tuberculosis, not the intensive phase alone. Option D, 9 months, is also incorrect because that refers more closely to the total duration of tuberculous meningitis therapy rather than the initial intensive phase. After completing the first 2 months, patients usually move into the continuation phase. This stage commonly lasts another 7 to 10 months and typically involves isoniazid and rifampin. Overall, tuberculous meningitis treatment often continues for 9 to 12 months in total. The prolonged duration is necessary because tuberculosis bacteria can persist deep within tissues and may reactivate if treatment stops too early. One of the most important principles in tuberculous meningitis management is starting treatment early. Doctors frequently begin anti-TB therapy even before laboratory confirmation is available because delays can lead to irreversible brain injury. In tuberculous meningitis, every day matters. Rapid treatment during the intensive phase can significantly improve survival and reduce the risk of long-term neurological complications. In tuberculous meningitis, or TBM, controlling the infection is only part of the battle. A major cause of brain injury in tuberculous meningitis comes from the body's intense inflammatory response. This is why certain supportive medications are used alongside anti-tuberculosis drugs to improve survival. The correct answer is C, dexamethasone. Dexamethasone is a corticosteroid that has been proven to reduce mortality in patients with tuberculous meningitis when used together with standard anti-tuberculosis therapy. It does not directly kill Mycobacterium tuberculosis, but it plays a crucial role in reducing harmful inflammation inside the brain. When tuberculosis bacteria enter the subarachnoid space, the immune system reacts aggressively. Thick inflammatory exudates can accumulate around the brain, blood vessels, and cranial nerves. This inflammation may cause swelling, hydrocephalus, vascular damage, and increased intracranial pressure. Dexamethasone helps suppress this excessive immune response. By reducing inflammation, it lowers pressure inside the skull and may decrease damage to vulnerable brain tissue. Clinical studies have shown that patients receiving dexamethasone are more likely to survive than those treated with anti-TB drugs alone. Because of this proven benefit, corticosteroids are now considered a standard part of tuberculous meningitis management in most patients, regardless of disease stage. The medication is usually given in high doses initially and then tapered gradually over several weeks. This slow reduction helps prevent rebound inflammation and allows the body to adjust safely. Although dexamethasone improves survival, it does have limitations. Some patients may still develop long-term neurological complications such as hearing loss, memory problems, seizures, or weakness, especially if treatment begins late. Option A, aspirin, has been studied for possible benefits in reducing stroke risk in tuberculous meningitis, but it is not the primary medication proven to reduce overall mortality. Option B, vancomycin, is an antibiotic used mainly for severe bacterial infections caused by gram-positive organisms. It does not play a role in treating tuberculosis meningitis. Option D, interferon gamma, is involved in immune system function and has been investigated in research settings, but it is not standard therapy proven to reduce mortality in tuberculous meningitis. The use of dexamethasone highlights an important concept in tuberculous meningitis treatment. Much of the neurological damage comes not only from the bacteria themselves, but also from the inflammatory reaction triggered inside the central nervous system. This is why successful treatment requires both antimicrobial therapy and careful control of inflammation. Anti-TB medications target the infection, while dexamethasone helps protect the brain from immune-mediated injury. In tuberculous meningitis, early recognition and rapid initiation of both therapies can significantly improve survival and reduce the devastating complications associated with this life-threatening disease. In tuberculous meningitis, or TBM, inflammation tends to collect around the base of the brain. This thick inflammatory material, called basal exudate, can surround and compress important cranial nerves as they pass through this region. The cranial nerve most commonly affected is cranial nerve 6, also known as the abducens nerve. So, the correct answer is B. The abducens nerve controls the lateral rectus muscle, which moves the eye outward. When this nerve becomes inflamed or compressed, the affected eye cannot move properly to the side. Patients often develop double vision, especially when looking sideways. Some may complain that their eyes feel misaligned or that objects appear duplicated. On examination, the affected eye may drift inward because the opposing eye muscles continue pulling unopposed. Cranial nerve 6 is especially vulnerable in TBM because of its long intracranial course. As it travels through the base of the brain, it passes directly through areas where inflammatory exudates commonly accumulate. Increased intracranial pressure can also stretch the abducens nerve, making it even more susceptible to injury during severe meningitis. Basal exudates are one of the hallmark pathological features of tuberculous meningitis. These thick inflammatory collections surround blood vessels, cranial nerves, and cerebrospinal fluid pathways near the brainstem. As inflammation worsens, additional cranial nerves may also become involved. This explains why patients with tuberculous meningitis can develop multiple neurological deficits affecting eye movement, facial expression, hearing, or swallowing. Option A, cranial nerve 3, controls several eye muscles and eyelid elevation. Although it can sometimes be affected in tuberculous meningitis, it is not the most commonly paralyzed cranial nerve. Option C, cranial nerve 7, is the facial nerve. Damage to this nerve may cause facial weakness or asymmetry, but it occurs less frequently than sixth nerve palsy in tuberculous meningitis. Option D, cranial nerve 10, the vagus nerve, is involved in swallowing and vocal cord function. While advanced brainstem involvement can affect it, this is far less common. The presence of cranial nerve 6 palsy is clinically important because it may serve as an early warning sign of increased intracranial pressure or significant basal meningeal inflammation. Doctors evaluating patients with persistent fever, headache, neck stiffness, and double vision should always consider tuberculous meningitis as a possible diagnosis, especially in regions where tuberculosis is common. Recognizing cranial nerve involvement early can help prompt urgent imaging, cerebrospinal fluid analysis, and rapid initiation of treatment before permanent neurological injury occurs. In tuberculous meningitis, even a subtle eye movement abnormality may signal serious inflammation deep within the central nervous system. Tuberculous meningitis, or TBM, is one of the few medical conditions where treatment often begins before laboratory confirmation is available. This is because the disease can progress rapidly and cause irreversible brain injury within a short period of time. In this scenario, the patient has a high clinical suspicion for tuberculous meningitis but a negative gene-expert ultra result. The correct answer is C. Start empiric anti-TB treatment and steroids immediately. A negative gene-expert ultra test does not rule out tuberculous meningitis. Although gene-expert ultra is highly sensitive and much faster than traditional culture methods, the number of tuberculosis bacteria in cerebrospinal fluid is often extremely low. Because of this low bacterial load, some patients with true tuberculous meningitis may still test negative on molecular testing. This is why doctors never rely on one test result alone when evaluating suspected tuberculous meningitis. Clinical judgment remains critically important. If the patient has symptoms such as fever, persistent headache, neck stiffness, altered consciousness, cranial nerve palsies, or characteristic cerebrospinal fluid findings, treatment should not be delayed. Starting empiric anti-tuberculosis therapy early can save the patient's life. The standard treatment usually includes isoniazid, rifampin, pyrazinamide, and ethambutol during the intensive phase. At the same time, corticosteroids such as dexamethasone are started to reduce inflammation inside the brain. Much of the neurological damage in tuberculous meningitis comes from swelling, vascular injury, and increased intracranial pressure caused by the immune response. Early steroid therapy has been shown to significantly reduce mortality in tuberculous meningitis patients. Option A, discharging the patient, would be extremely dangerous. A patient with strong clinical suspicion for tuberculous meningitis requires urgent medical evaluation and treatment because delays can lead to coma, stroke, or death. Option B, waiting for culture results before starting therapy, is also incorrect. Tuberculosis cultures may take 2 to 8 weeks to become positive. Waiting that long in suspected tuberculous meningitis could allow devastating neurological damage to occur. Option D, performing a brain biopsy, is rarely the first step in management. Brain biopsy is invasive and usually reserved for very unusual or unclear cases when other diagnostic methods fail. One of the most important principles in tuberculous meningitis management is that treatment decisions are often based on probability rather than absolute proof. In high-risk situations, the danger of delaying therapy is far greater than the risk of starting treatment early. Doctors combine clinical findings, cerebrospinal fluid analysis, imaging studies, and laboratory tests to make the diagnosis. Even when molecular tests are negative, strong suspicion alone may justify immediate therapy. In tuberculous meningitis, early action can mean the difference between full recovery and permanent neurological disability. Hyponatremia is a very common and potentially dangerous complication of tuberculous meningitis, or TBM. Hyponatremia simply means that the sodium level in the blood has dropped below normal. Since sodium plays a major role in nerve and brain function, low levels can quickly worsen a patient's neurological condition. The correct answer is B. Syndrome of inappropriate antidiuretic hormone secretion, commonly called SIADH. In tuberculous meningitis, inflammation around the brain can disrupt normal hormone regulation. One of the hormones affected is antidiuretic hormone, or ADH. This hormone normally helps the body control water balance by telling the kidneys how much water to retain. In SIADH, too much ADH is released. As a result, the kidneys retain excessive water. This extra water dilutes the sodium in the bloodstream, causing hyponatremia. Patients with SIADH may develop symptoms such as nausea, headache, confusion, irritability, muscle cramps, or worsening lethargy. In severe cases, very low sodium levels can trigger seizures, coma, or even respiratory failure. Hyponatremia is especially concerning in tuberculous meningitis because many patients already have brain inflammation and increased intracranial pressure. A sudden drop in sodium can worsen cerebral edema and rapidly deteriorate neurological function. Doctors closely monitor sodium levels in tuberculous meningitis patients because correcting hyponatremia safely is extremely important. Rapid or improper correction can also cause serious neurological complications. One challenge is that another condition called cerebral salt wasting, or CSW, can also occur in tuberculous meningitis. Both SIADH and cerebral salt wasting cause low sodium levels, but the mechanisms are very different. In SIADH, the body retains too much water. In cerebral salt wasting, the kidneys lose excessive amounts of sodium and water. Distinguishing between these two conditions is critical because their treatments are different. Option A, overhydration, may worsen hyponatremia but is not considered the primary underlying cause in most tuberculous meningitis patients. Option C, hyperaldosteronism, usually causes sodium retention rather than sodium loss, making it the opposite of what is typically seen in tuberculous meningitis-related hyponatremia. Option D, renal failure, can sometimes contribute to electrolyte disturbances, but it is not the most common explanation for hyponatremia in tuberculous meningitis. The relationship between tuberculous meningitis and SIADH highlights how tuberculosis can affect much more than just the meninges. The infection disrupts hormonal balance, fluid regulation, and brain function simultaneously. This is why tuberculous meningitis management requires careful monitoring of neurological status, electrolytes, fluid balance, and intracranial pressure throughout treatment. In tuberculous meningitis, even a laboratory abnormality like low sodium can become a medical emergency if not recognized and treated early. In patients with tuberculous meningitis, or TBM, worsening symptoms after starting treatment can be extremely alarming. At first glance, it may seem like the medications are failing or the infection is getting worse. But sometimes, the opposite is actually happening. The correct answer is B. Immune reconstitution inflammatory syndrome, commonly known as IRIS. IRIS is most commonly seen in patients with HIV who begin antiretroviral therapy, or ART, while also receiving treatment for tuberculosis. As the immune system begins to recover, it suddenly becomes much more active and mounts a strong inflammatory response against remaining tuberculosis antigens. In simple terms, the immune system wakes up and reacts aggressively to an infection that was already present. In TBM, this inflammatory reaction can become especially dangerous because it occurs inside the central nervous system. Existing brain lesions may enlarge, inflammation may increase, and new neurological symptoms can appear even though the anti-tuberculosis medications are working. Patients may develop worsening headaches, fever, seizures, confusion, or new focal neurological deficits. Brain imaging may show enlarging tuberculomas, increased edema, or worsening meningeal inflammation. One important clue is that repeat cultures are often negative. This suggests that active bacterial growth is not the primary problem. Instead, the symptoms are being driven by an exaggerated immune response. This is what distinguishes IRIS from treatment failure. Option A, treatment failure due to resistance, would usually involve persistent or growing infection caused by ineffective medications. In those cases, cultures or other tests may still show active tuberculosis bacteria. Option C, new-onset fungal meningitis, is possible in immunocompromised patients, but would not typically explain worsening TB lesions with negative repeat cultures immediately after starting ART. Option D, cerebral malaria, is unrelated to the pattern described in this scenario. IRIS highlights one of the major challenges in treating HIV-associated tuberculous meningitis. Restoring immune function is essential, but rapid immune recovery can also trigger severe inflammation in vulnerable tissues like the brain. Doctors managing tuberculous meningitis with HIV must carefully balance anti-tuberculosis treatment, corticosteroids, and the timing of antiretroviral therapy. In some patients, corticosteroids may need to be increased temporarily to control inflammation caused by IRIS. Despite the dramatic clinical worsening, IRIS does not necessarily mean the TB treatment should be stopped. In many cases, both anti-TB therapy and ART are continued while the inflammatory response is managed supportively. Recognizing IRIS early is critical because it prevents unnecessary changes in treatment and helps doctors respond appropriately to the immune reaction. In tuberculous meningitis, a patient can sometimes worsen not because the immune system is weak, but because it is suddenly becoming active again.